Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. PervezAli, working as Associate Professor of Orthopedic Surgery, and today my topic of presentation is clinical evaluation and on the vertical talus with differential diagnosis. This is our hospital we are working, and this is my pediatric orthopedic team with dedicated pediatric OR. And this slide shows our clubfoot clinic. In this clinic, we are dealing with clubfoot patients, vertical talus, and CKD patients. So, first of all, definition. The first we describe the vertical talus. The Tejarin is described. Vertical talus is basically the dorsolateral dislocation of the talonavicular joint. In vertical talus, the navicula is dislocated dorsally and talar head dorsally on the talar head and the neck. The talus is oriented vertically, leading to the fixed equinus contexture of the hind foot and rocker bottom foot. You can see in this picture there is a plantar surface, there is a convex surface is indicated for the rocker bottom, and heel is C on the equinus deformity with valgus. The it's a very rare condition, 1 in 10,000. There's a male to female, it's the same ratio. The usually is 50% bilateral. The first is described by the Hankin in 1914, and there are several synonyms. There's a rocker bottom feet, reverse club foot, congenital convex pes valgus. And the pattern means, as I told you, there's a dorsal talonavicular dislocated dorsally, and the plantigrade talus. It is a very rigid. They are associated with the abduction and dorsiflexion of the foot due to contexture of the abductor hallucis longus and extensor hallucis longus, as well as tendinochleus is very tight. So that's why hand foot is equinus. The exact etiology is not known, but 50% of cases is associated with, like as I told you, that the contexture of the extensor and extensor digitorum, extensor hallucis, and tendinochleus. The genetic syndrome gene defect on the chromosome 13, 15, 18, 30, and 31, and there's a positive family history in 20% of cases. There's associated neuromuscular abnormalities like arthrogryposis, MMC, spina bifida, and cerebral palsy, sometimes neurofibromatosis. Therefore, there's a clinical and neurological genetic workshop is want. The clinical presentation, as I told you, they are typically noticed at the birth, infancy. The foot is rocker bottom, and there's a limited or absent on the movement during the manipulation. Late presentation, usually the foot of the baby is like a packed leg gait, painful callousy on the dominant areas of the foot. On physical examination, on the inspection, there is a convex surface on the medial talar head prominence. There is a palpate rigid fixed deformity. On the manipulation, lack of correction of positive dorsiflexion and assessment of Achilles tendon, which is usually very tight. And neurological examination rule out, see the spina bifida and MMC and secondary. Bilateral association is some is present, but the gait is typically like a peg leg and a calcaneal gait due to push off the surface. In general inspection, the posture of the foot is a plantar surface, rigid equinus bottom deformity, convex of the sole of the foot due to dislocation of the navicula and the plantigration of the talus. Foot in the everted in valgus and extremely rotated in position. The hind foot in equinus, prominent the medial talar head, especially when foot is dorsiflex. And on the, so you see on palpation, there's a talar head predominance on the medial, dislocated especially on the palpation of the subcutaneous view. There's a rigid deformity, see on the plantigrade and dorsiflexion of movement, it's a very rigid, and see that when you do the dorsiflexion on foot, the tendon is very tight, so that's why you see the heel in the calcaneum. And heel is palpable, heel feels soft, and calcaneum may feel prominency possibly due to the plantigulation of the attitude of the foot. On the manipulation, dorsiflexion, as I already do the dorsiflexion midfoot instead of the ankle. Okay. And the heel bisected line, usually in the vertical talus, the line is bisecting at the level of the fourth and fifth metatarsal. In normal foot, it is between the second and third. The reverse Reversibility test is a gentle manipulation failed due to reduction of the navicular onto the talar head. It is bridging between the oblique talus and vertical talus, because in the vertical talus the navicula is fixed, so it cannot reduce on the plantigration. But in the like oblique talus, it is reduced with the plantigration of them. And you can see the jaw thrust which create for the arch of the foot, like in physiological flat foot. It is usually jaw thrust make a arch on the medial surface, but like in a typical vertical talus there is no medial arch formation. Neurological examination, you see the muscle assessment, hypotonia, sensation of the nerve, and the power of the nerve, and there's a spinal examination. And so bilaterally assessment for the associated like chromosomal spinal bifida, arthrograph, hip dysplasia associated examination mandatory, and as well as the knee examination is very important. Sometimes vertical is associated with the congenital knee dislocation. Differential diagnosis of vertical talus, as I told you, there's a different like oblique talus, there's a pes planus, tarsal collision, and there's a club foot reverse position, and there's a muscular neuromuscular disorder like a cerebral palsy and the calcaneovalgus foot and congenital oblique talus. The question is how you add and the clubfoot in differential diagnosis of vertical, because if you not do the tenotomy, you could just correct the abduction and dorsiflexion of the clubfoot, so it create the midfoot movement, so it form a rocker bottom foot development. The radiologically AP and lateral view is very important. On the AP view, you see the increased kite angle, and the plantar flexion, you see the foot in forefoot fix. And lateral well bearing angle is very important to see the Mary's angle between the long axis of the talus and metatarsal. It is more than 20 degrees. The dorsiflexion lateral view fixed equinus of the foot. The, on the it's a short review. That is congenital awareness. It is incident is unknown, common, and condition may occur as isolated and primary deformity with the CNS, and musculoskeletal deformity may be sometimes multiple, one or multiple anomalies of the trisomy, like the chromosome 13, 15, 18. Clinically, as I told, okay, this is a rigid deformity and usually not plantigrade of the foot, and usually rocker bottom foot, and the head of the talus is markedly prominent on the medial and plantar surface. The foot is abducted and also flexed at the mid-tarsal joint. The severe pes planus have vertical talus but not equinus. Rocker bottom treated clubfoot has a pursuant equinus but not a plantigrade talus. The radiological finding, the equinus deformity, hindfoot and valgus, forefoot and valgus. There is a primary dislocation of the talonavicular joint, navicular articular surface on dorsal face of the talus, locking it on the plantar surface of vertical position. Subluxation of the adjacent joint resulting rocker bottom deformity associated to. The conclusion of presentation is early and accurate clinical evaluation is the key to the diagnosis. Require high index of suspicion and skills evaluation. A radiograph will confirm the diagnosis, but clinical sign guideline the urgency for the help in the treatment. Thank you very much.